Hi, good afternoon. So we'll start today's class. Today's session is on epilepsy and preoperative evaluation. So we'll cover it under the following topics. First, just a general clinical evaluation of surgical epilepsy cases. And how do we evaluate them with radiology and electrophysiology? So the first section is on clinical evaluation of surgical epilepsy. The main goal of evaluation in epilepsy cases is to identify something known as the epileptogenic zone. The epileptogenic zone is basically either a focus, like one single area where epilepsy arises from, or it might even be a network. There might be multiple different areas which together contribute to this patient's epilepsy. But you have to remember these two words, epileptogenic zone. That is the basic goal of the entire epilepsy evaluation. So the clinical approach to any epilepsy case is first you have to diagnose that the patient has drug-resistant or pharmacoresistant epilepsy. That is only established if there is a failure to respond to two or more appropriately chosen anti-epileptic drugs. And it should be established that the therapeutic levels of these drugs are sufficient in the blood. Okay, but you at least have to have tried two anti-epileptic drugs before you can label it as a pharmacoresistant epilepsy. After you have established the diagnosis of pharmacoresistant epilepsy, then the seizure semiology should be defined. Because as we had discussed in the last class, the seizure semiology, specifically how the seizure starts, that describes where the seizure is originating from. So in particular, the patient's aura, that is a very good indicator of where the seizure is beginning from. And so according to the whole idea of operating this patient, if you remove the particular focus where the seizure is arising from, the seizure should stop. After this, a neurological examination is performed to uncover any pre-existing deficits because a lot of surgeries which are done for epilepsy cases do tend to induce deficits. So it's always important to know what are already pre-existing deficits because a lot of these patients would have hemispheric damage or particular lobar damage. So you have to rule out particular deficits before surgery itself. Okay, so once you have these basic clinical counterparts ready, you can go on to further localizing your uh, epileptogenic zone. There are two main techniques which are used for localizing the EZ. That is the first is a high resolution MRI, and the second is video EEG monitoring. So the high resolution MRI is done under a particular epilepsy protocol known as harness MRI, where there are three different sequences. There is a 3D volumetric T1 weighted sequence, a 3D flare sequence, and there's a 2D coronal T2 weighted sequence, which is created perpendicular to the long axis of the hippocampus. So, okay, so this sequence obviously is most important for mesial temporal sclerosis when you're trying to look for hippocampal atrophy. In a normal harness MRI, gadolinium is not used. Contrast MRI is only indicated if you're suspecting there is a particular tumor, there is a vascular lesion, or there is an active infection in this patient. It is also very important that this MRI has to be interpreted by a neuroradiologist who is active in an epilepsy program, because it has been found that a neuroradiologist, who's active in an epilepsy program, if they interpret the MRI, the sensitivity is a lot higher than a normal standard neuroradiologist interpreting these MRIs. But it is also important to remember that if the patient has a normal MRI, does not mean that there's no role of epilepsy surgery. There are a lot of patients who have a normal or a negative MRI, or maybe some confounding factors on MRI, who can still go ahead and have epilepsy surgery. The second important technique for localization of EZ, at least at level 1, that is the most basic level of pre-surgical evaluation, is video EEG monitoring. This is basically two different components. You take a video of the patient while they're there in the video EEG suite, and also you're constantly monitoring their EEG. Usually, it is a prolonged monitoring, at least for 24 to 48 hours. So this allows you to pick up both the interictal and the ictal EEG. So you get idea of where are the spikes coming from. And second, it allows you to even pick up the seizure semiology. So you get both clinical as well as electrophysiological data from a video EEG. Right. So once you have the patient's clinical details, you have the MRI, and if you have the video EEG details, that is your level 1 evaluation. So that is done for all patients considered as candidates for surgery. So once this is ready, you can have a patient management conference. So patient management conference is done in particular epilepsy centers where there are epileptologists, epilepsy surgeons, neuroradiologists, and neuropsychologists who will evaluate these patients and figure out if they're good candidates for surgery. So all the data as we discussed, the anatomic data, electrophysiologic data, and clinical data is integrated into a clear pre-surgical hypothesis. This is also known as an AEC hypothesis, which is an anatomic, electrical, and clinical hypothesis. So that's what it's called, AEC hypothesis. Now, if this data suggests that your epileptogenic zone, it is in one particular area, then a particular surgical strategy can be proposed. If you can localize your EZ with the level 1 testing, then you can have a particular surgical strategy. If you cannot, your MRI is normal or any of your data is discordant at any level. Remember, there are three different components to the data. There's anatomic, there's electrophysiologic, and there's clinical. Okay, anatomic obviously means the MRI. Okay, so if any of this is discordant or the MRI is normal, you require further additional testing. So what are the additional diagnostic testing that is available to us? So this is when you are not sure on level 1 that the patient is a safe candidate for surgery. Every time that you are evaluating a patient for surgery, you have to ask at every stage, is this patient now a safe candidate for surgery? So if you don't think the patient is a safe candidate for surgery, you have to go on to additional diagnostic testing. One of the most common tests we would do is a PET. And the most common tracer used for epilepsy is fluorodeoxyglucose. So FDG PET is usually done in these patients. Now, it's usually done only in patients who have a negative MRI or a discordant MRI. If your pre-surgical hypothesis has already been confirmed with your MRI and it's already quite clear, there is no need to do any of this additional diagnostic testing. A second test we can do is the ictal SPECT. Now, this is most useful in focal epilepsies, okay, where the MRI is normal, and also it can be useful in patients who have FCD. MEG, on the other hand, is a very highly advanced level of testing you can do. It's rather than an imaging technique, it's actually an electrophysiologic technique. You should think of MEG like an EEG, okay, rather than or like an MRI. Okay, so MEG particularly is very good for certain areas of the brain, usually like surface areas or sulci or some of the deeper areas. We'll discuss more about MEG in a little bit later in detail, but it's very important for detecting epileptiform discharges in opercular regions. It can also, apart from localizing where your electrical activity is coming from, be useful for functional localization. You can localize functional cortex with it. You can localize where your somatosensory cortex, your visual cortex, and your auditory cortex also. It is actually quite good for being able to localize functional cortices, and we'll discuss this in more detail later. There are also other things you can do with additional diagnostic testing with just an MRI itself. You can take a normal standard harness MRI and you can post-process it further. You can do a voxel-based morphometric analysis where every voxel is analyzed morphometrically and you're able to pick out subtle lesions. Especially this is useful for subtle cases like FCD. You can also do an automated hippocampal volumetric analysis and can pick up subtle hippocampal sclerosis. We can also go ahead with a functional MRI. Functional MRI is sort of comparable to MEG in the two things it can do. One, it can identify locant regions of the brain. And second, it can even pick up interictal epileptiform activity. So that is a technique known as EEG fMRI, and we'll come to that later as to how it works. The next thing is invasive evaluation techniques. So once you are done with your level 1 testing and even your level 2 additional diagnostic testing, sometimes you're still not sure. You still don't think the patient is a safe candidate for surgery. So that is when invasive evaluation comes in. So there are particular indications for invasive evaluation. One is that your MRI turned out to be negative or discordant with your electroclinical hypothesis. You did all your testing, but things are not matching. Okay, so you want to further evaluate with what would be considered as a gold standard for localizing the epileptogenic zone. It would be invasive techniques. The second thing is if there are multiple potentially epileptogenic lesions. You have cases like tuberous sclerosis or periventricular nodular hyperplasia, where there are multiple lesions. You just don't know which lesion is causing epilepsy. And so in these cases, you can invasively go in, put an electrode into these lesions and see where is the epileptogenic zone. And Third, and actually quite important, is if your pre-surgical hypothesis involves eloquent cortex. You have a lesion in the Broca's area, you have a lesion in the motor strip, you have a lesion in the visual cortex, and you want to see if the lesion is in those areas or it is just surrounding those areas. If it can be safely resected without damaging this eloquent cortex, and the best way to do this is with invasive evaluation techniques. There are basically two invasive evaluation techniques. One is a subdural grid, and second is a stereo EEG. And there are multiple different indications for both. Okay, but so we'll discuss in more detail later, but at this point, it is only important to remember that if the patient is MRI positive, that you have some sort of a hypothesis. Okay. And if the lesion is in a non-eloquent cortex, then you don't need anything more. Okay. You just, everything is sorted out for you. Patient is a safe candidate for surgery. You can proceed. But if the lesion is in an eloquent cortex, the first choice would be to do a subdural grid, and we will discuss why later. But the only indication currently for a subdural grid is a patient with a lesion in an eloquent cortex, because depth electrodes that we use in stereo EEGs are not very good at mapping a cortex. So the best thing to map a cortex would be subdural grid. Okay, so that is the main indication currently for the use of subdural grids. Everything else you would use stereo EEG. You have more than one lesion, you have a depth, you have a deep lesion, you don't have any hypothesis. Your MRI is negative, you're trying to figure out where the lesion is, etc., etc. That's where stereo EEG comes in. The only one role that subdural grid has is for a lesion in an eloquent cortex. Right, so this is the comprehensive algorithm for pre-surgical evaluation. It looks slightly scary, but nothing to worry about. As we discussed, there is phase 1 and there's phase 2. So when a patient comes in with drug-resistant epilepsy, just a comprehensive clinical history and evaluation is the most important thing first. First, establish it as drug-resistant epilepsy, establish that the patient is taking anti-epileptic drugs properly, and rule out any contraindications for epilepsy surgery. So that is, you're just trying to first establish if the patient is a good candidate for surgery, followed by your basic level evaluation, high resolution brain MRI, long-term video EEG monitoring, neuropsychological testing. That is the three main things you have to do for all patients at level 1. Okay. Now, if this indicates that the patient is a good candidate for surgery, the patient can directly proceed for surgery. But if you have any doubt in this, you think the patient is not a safe candidate for surgery, you go on for your non-invasive evaluation with your FDG PET, SPECT, MEG, fMRI, VADA testing, all depending on what you're trying to find out. You're trying to find out if the patient's lesion is in a eloquent area, then you would do things like VADA testing and fMRI. You're trying to find out where is the epileptogenic zone, then you would do a PET, a SPECT, or maybe a MEG. Okay. Now, if with this, you're able to figure out that the patient now is a safe candidate for surgery, they can proceed for surgery. Even with this, you do not think the patient is a safe candidate for surgery, then they might need to go in for intracranial invasive monitoring. But that is to be done only if, with all the testing that you've done so far, you have a testable hypothesis. You have a hypothesis saying that the lesion could be here. If you do not have such a hypothesis, the patient should not be subjected to intracranial invasive monitoring. You don't have a hypothesis, or your lesion is not localizable with whatever testing you have done, the lesion is not resectable, you have to find other ways to treat the patient. You cannot do resective surgery. Okay, so there are multiple other things you can do, like neurostimulation, palliative surgeries, etc., etc. But at the end of this, you have to remember that at every stage, you have to ask yourself, is the patient now a safe candidate for surgery? If not, more testing. If not, more testing. At any point, you're trying to figure out that the hypothesis is not testable, you don't have a hypothesis, the lesion is not resectable, the lesion cannot be localized, you have to go in for palliative surgeries only, or maybe just continue anti-epileptic drugs. Right, so that is about the clinical algorithm for evaluation of epilepsy patients. Now coming to the second section, that is a radiological evaluation. First, we'll just discuss how the most important imaging modality which is necessary for MRI for epilepsy and how does it work. That is the MRI. The indications for MRI in epilepsy is that MRI should be done for all patients with epilepsy unless you're absolutely sure that it is a non-lesional epilepsy. Okay, so unless you're clear that it is an idiopathic generalized epilepsy or it is a benign Rolandic epilepsy of childhood with centrotemporal spikes, which will resolve by itself later on. So unless you're clear, it is these two types. MRI should be done for all epilepsy patients. As we know already, epilepsy protocol is the 3T MRI and harness protocol. Sometimes you can do some optional sequences extra apart from the harness protocol, like a magnetization transfer imaging. A magnetization transfer imaging, here the images are obtained with both with and without a magnetization transfer. So following which you develop a magnetization transfer ratio, and a low magnetization transfer ratio indicates MTS. So sometimes you're not able to pick up MTS simply with a normal MRI. So this magnetization transfer imaging and even a T2 weighted relaxometry imaging can help you to pick up subtle MTS. So T2 relaxation time is actually higher in patients with MTS, and you can weight the images, particularly to look for this T2 relaxation time and pick this subtle MTS up. You can also do diffusion weighted imaging. With persistent seizures, you can see diffusion restriction at the point where the seizure has originated and even along the areas of propagation. And we'll see later how MRS also works to pick up epileptogenic zones. So this is a case of hippocampus sclerosis, and there are very obvious and very clear findings that you should look for in patients with mesial temporal sclerosis. You'll see on T1 mirrored images, as we can see here, there's hippocampal atrophy. The second thing would be increased signal intensity on T2 and flare images, as we can see here. There will be temporal horn dilation. And if you look at other structures which connect to the hippocampus, there would be atrophy. So there's an atrophy of the outflow tracts, so the parahippocampal gyrus, the ipsilateral pharynx, and the ipsilateral mammillary body atrophies. And there's an atrophy of structure which will indirectly connect to the hippocampus, like the temporal lobe, the thalamus, and even the choroid can also be atrophied. Another common feature you might find on MRI are malformations of cortical development. These usually give rise to congenital epilepsies. And so they're divided into two groups. The first group is basically going to arise from a proliferation of neuronal and glial cells. So this is where the cells are abnormally proliferating, or they might not be proliferating enough. So you can have microcephaly, macrocephaly, hemimegalencephaly. So clearly related to size. And other tumor-like things like tuberous sclerosis, DNETs, gangliogliomas, and gangliocytomas also fall into group 1. FCD type 2A and 2B, that is without and with balloon cells, also falls into group 1. So here you can see tuberous sclerosis with these clear nodules which are present over here. And this is a case of tuberous sclerosis with SEGA in this frontal horn. This is a case of hemimegalencephaly over here. So you can see one side of the hemisphere is quite large. So they're all group 1 malformations. Group 2 malformations, on the other hand, result from abnormal neuronal migration. So that is where the neurons that are supposed to migrate from the ventricle to the cortex have not migrated properly. So they probably got lost and got stuck somewhere in the middle along the way. So this usually leads to heterotopias, but also can lead to lissencephaly. So as you can see here, there is gray matter next to the ventricle, next to the ependyma. So this is subependymal nodular gray matter heterotopia. Okay. And you can see this band of cortex below the gray matter. So this is band heterotopia. So group 2 lesions. Group 3 lesions, on the other hand, directly affect the cortex. So they result from abnormal cortical organization. These include defects like polymicrogarias, schizencephaly, and type 1 FCDs. Okay, so focal cortical dysplasias, there are basically two types, and they're the most common cause of epilepsy in children. Type 1 FCD and type 2 FCD can be actually quite easily differentiated. Type 1 FCD, the most important thing to remember is it is frequently located in the temporal lobe. Type 2 FCD, on the other hand, is most frequently located in the frontal lobe. Okay. Other more subtle things which can help you are type 1 FCD can actually be quite difficult to pick up. It might not be as obvious as you can see here as type 2 FCD maybe. Type 2 FCD is a little bit more obvious. Okay. So you will see there might be hypoplasia or aplasia or atrophy at the lobar or sublobar level. So you can see as compared to this side, this temporal lobe is smaller. You can also see subcortical white matter volume loss. And this subcortical white matter will be T1 hyper and T2 hyper. There will be a mild gray-white blurring, and it is also frequently associated with other developmental tumors. Type 2 FCD, on the other hand, is a little bit more obvious, as we can see here. Here, the cortical thickness actually increases. There is also gray-white blurring here, but it is a little bit more obvious as compared to type 1 FCD. The subcortical area is T2 hyper and T2 hypo. Also, it tries to create a funnel track between the cortex and the ventricle. Okay. As we discussed already at the predilection of a frontal lobe, and there are two types of type 2 FCD, type 2A and type 2B. with dysmorphic neurons, both of them, but type 2A has no balloon cells and type 2B has balloon cells. You cannot distinguish both these steps on MRI, and really does not really make a difference to distinguish these based on MRI either. Okay, so next, coming to functional imaging. Functional MRI is one of the most commonly utilized techniques these days to figure out where is your eloquent cortex. But apart from that, it can also be used to pick up epileptic activity. So functional MRI currently can map language, motor function, memory also, and even epileptic activity. So what we do with a functional MRI is the patient has to perform a particular task that is known as a functional paradigm. And because of which, whichever areas are involved in the brain, the perfusion there will increase, and the ratio of the oxyhemoglobin to deoxyhemoglobin increases, creating a bold signal. That's a blood oxygen level dependent signal. So you can use this bold signal to figure out what is the areas of interest. There are obvious limitations to this. That is influenced, first of all, this area is influenced by thresholding. Whatever threshold you decide, that will pick out what areas light up and what areas don't light up. There is also no clear definition between area of bold intensity and eloquence. Just because an area lights up more than another area does not mean that it is the eloquent region for that particular function. Those areas that light up might actually not even be important to carrying out that function. And just because an area lights up does not mean it is crucial to the task. Just removing it might not actually even affect the task completely. When it comes to localizing motor function, it has been found that functional MRI has an 84% correlation with direct cortical stimulation, which is quite good for motor function. And language, fMRI has high levels of concordance with VADA for lateralization. But its usefulness for localization on the particular hemisphere is less clear. But it is able to lateralize to one side at least. The third thing that it can do is pick out epileptic activity. So that is done with an EEG fMRI. Here, the functional paradigm is not an activity that the patient performs. It's actually the presence of epileptic activity in the brain. So the patient is undergoing an EEG and they are being mapped for epileptiform discharges. Whenever these discharges happen, that is when the board level changes are happening in the brain are also picked up at the same time. Now, it is important to remember that a lot of these discharges will be interictal activity. And interictal activity does not localize very well to the epileptogenic zone as ictal activity would. Okay. So it has been found that in patients who do have refractory focal epilepsy, 50% of patients have interictal discharges, okay, during EEG fMRI recording, and they do show bold changes, at least 50% of them. So the correlation that has been found between the electroclinical localization of EZ and the bold signal has been only 40 to 60%. Because, first of all, most likely it is picking up interictal activity. And as we saw, bold changes have a lot of limitations. So not the best technique, but it is a technique to pick out epileptic activity. You can also do diffusion-weighted imaging that is not really to localize the epileptogenic zone, but basically to figure out what is the eloquent regions around the epileptogenic zone. So to evaluate the role of the relationship between the EZ and the subcortical fibers. So for the cortex, we use fMRI. For subcortical fibers, we use diffusion-weighted imaging and DTI. So another role that DTI can play is actually in disconnection surgeries. So in corpus callosotomy, for example, you can do a DTI and see if all the fibers have been transected or not. So that can guide further surgeries also. We can also use MR spectroscopy. So there are multiple indications. One is that MRs can differentiate a tumor from an FCD. So sometimes you're just not sure if it's a tumor or an FCD. The tumor would have low levels of Na, increased levels of choline, and an elevated choline creatinine ratio, which would not be present in an FCD. Sometimes a proton MRS can also be used to detect if there are areas of damage on a normal appearing MRI. The MRI may appear normal, and the MRS may pick up low Na signals from certain areas, which will help you to localize that maybe epilepsy is coming from certain focus. Apart from this, MRI can also be used for interventions. So that is for intraoperative MRI in epilepsy surgery. It has been found that in lesional temporal lobe epilepsy, which was non-hippocampal sclerosis, it actually increased the resection rate by 21.6%, and they were able to achieve complete resection in 96.6% of patients with the use of interventional MRI. For extratemporal lesion, it also helped them to identify incomplete resection in about 20%. So as you can see, intraoperative MRI can help you achieve that complete resection in about 20% extra patients. Okay, now coming to other radiologic techniques, like SPECT. SPECT is it's very simple, but it is a very labor. It is just a highly labor intensive technique for localization of epileptic zones. So SPECT is single photon emission computed tomography. The most frequent indication of using SPECT would be when you have a non-lesional focal epilepsy. Your MRI is normal, but it is a focal epilepsy. So a SPECT may be able to find you a potential target to implant electrodes. SPECT by itself cannot tell you that this is your zone. Okay, but it can help you figure out where could you implant electrodes in a patient who has a normal MRI. Okay, so how it works is basically it assesses cerebral blood flow. You have these radiopharmaceuticals that you've already prepared. You inject them at the time of the seizure, and then they get distributed proportional to blood flow in the brain, and they remain stable up to 4 hours over there. So the common material that we use is 99mm technetium. So here, what we do is an ictal SPECT. So it evaluates hyperperfusion during a seizure. The techniques that you can use include a post-ictal or inter-ictal SPECT. So it evaluates hypoperfusion after or between seizures. So it is important to remember that during a seizure, that area will be hyperperfused, and after a seizure, it will be hypoperfused. So an ictal SPECT usually uses two tracers, a 99mm technetium HMPAO or a bicassette. So these both have very high first pass brain extraction. So as soon as you inject them, they get picked up by the brain, and they will get deposited in the brain within 30 to 60 seconds of injection. The reliability of an ictal SPECT depends on what was the time that you gave this injection and whether that particular seizure when you gave the injection is actually representative of the patient's seizure or not. So the ideal time is within 45 seconds. We also do an interictal SPECT where a separate interictal SPECT is performed just to provide what is a baseline context. A SysCom, that's a subtraction ictal SPECT co-registered to MRI, is basically a ictal SPECT and an interictal SPECT subtracted, and then this is fused to an MRI. So this is a SysCom image. Here the interictal SPECT has been subtracted from the ictal SPECT to be able to show you what areas should light up, and then this is co-registered an MRI. This can be further improved with something called a statuscom. So here you take the patient SPECT scans and a set of paired SPECT scans from normal subjects, and then these are statistically compared to give you an idea as to what are potentially localizable easy areas. The problems with SPECT is that it is a time and resource intensive technique. The radioisotope agent, as we discussed, has to be injected immediately, more or less, within 45 seconds. And SPECT data usually demonstrates more than one hyperperfused region. So that makes interpretation quite difficult. So as we discussed, SPECT is not to particularly localize the EEG, but to give you an idea as to where you should implant the electrode. The sensitivity of SPECT can be quite good. It is actually 0.97 for ictal SPECT. But for immediate post-ictal SPECT, if you give the tracer within 5 minutes, it is 0.75 only. And for interictal SPECT, it is 0.44. Okay, so then let's discuss magnetoencephalography, one of the newer and slightly complicated techniques which we use for localization of epilepsy. So first of all, MEG is an encephalography technique. It's not an imaging technique. Okay, so MEG has to be compared to EEG and not to MRI. Okay, but ultimately it does work with imaging. So it is called as magnetic source imaging. MSI is basically a specific type of MEG application. It is not just MEG. MSI and MEG are not synonyms. So MSI is a way that MEG is used for the purpose of localizing dipoles within the patient's MRI. Okay, so MEG is a direct non-invasive neurophysiology technique which basically studies the brain's magnetic fields. After studying these magnetic fields, you get electrical activity by estimating these dipoles, and then you will co-register this with the patient's MRI. That is magnetic source imaging. Now, where do these magnetic fields come from? Basically, whatever activity is going on in the brain, all the activity will obviously be electrical activity. And this activity is picked up particularly from the postsynaptic intradendritic currents. So whatever is the summated currents after the synapse in the dendrite, that summated current creates these magnetic fields that are picked up by the MEG sensor. So these fields get reflected outside the skull and they will be recorded by supersensitive magnetic sensors. But obviously, as you can imagine, these magnetic fields will be very, very weak. They're being produced by your brain, right? So there are two main problems with detecting these magnetic fields. They are very, very, very weak. So they require very strong sensors. And literally any tiny magnetic activity can distort these. So this MEG machine requires extensive shielding from the normal hospital environment. So the sensors for a MEG usually consist of small coils or chips, which function as something known as flux transformers, which are coupled with a structure known as squid. Okay, the only thing to remember here is it works on two quantum physics phenomena, superconductivity and tunneling. The important one to remember here is superconductivity. Okay, because the only thing to remember here is superconductivity requires extreme levels of cooling, which requires helium. If you're going to use helium, it is going to become very, very expensive. That is why MEGs are very, very expensive. Now, the current systems which use MEG have more than 300 of these sensors, which are arranged in a helmet-shaped configuration around the head to pick up these brain magnetic activities. Now, as we have discussed multiple times, a MEG should not be compared to an MRI, but should rather be compared to an electrophysiology technique like an EEG. Now, a MEG is superior to an EEG in multiple ways. First of all, an EEG, as you would have seen, has only 20 to 30 electrodes. But MEG has extensive spatial sampling. It is sampling from hundreds of different locations surrounding the brain. A MEG would not be distorted by intervening tissues. As we know, the EEG is distorted by scalp, surgeries, etc., but MEG is not. MEG is free of any biological references. We do not require any electrodes to pick up MEG activity. And it can detect a smaller activated area as compared to EEG. EEG usually has a sensitivity of about more than 10 centimeters square, but MEG can pick up 2 to 6 centimeters square areas also. The problems with MEG are that, as we discussed, superconductivity, helium, high costs. Other things, there's a significantly magnetically shielded environment which is needed for MEG activity. The equipment is immobile. EEG can be carried anywhere and used. MEG cannot be. It is susceptible to both movement and metallic artifacts. And whatever data is produced by a MEG, it requires a lot of analysis before it can be interpreted. And as we will see in the next slide, it is sensitive only to tangential sources. Okay, so what do we mean by that? So just if you remember Maxwell's rules, basically whatever electricity is produced or whatever current is produced by a wire, for example, the magnetic field produced by that current is given by the right-hand rule. So if you have a vector which is demonstrating where your current is going, for example, in this direction, this is the wire and this is how the current is flowing, the right-hand rule will give you the direction of the magnetic fields. Okay. So the sources which are generating these magnetic fields can be either tangential sources or radial sources. Okay. So your tangential sources are basically sources which are oriented parallel to the skull. Okay. So as you can see, these sources, this is the electrical. You have to imagine that the current is traveling from the cortex into the white matter. Okay. So this is the direction of the current. Okay. As you can see, this is the direction of the current here. And this, as you can see, is parallel to the skull. This is the tangential source. This, on the other hand, the red one is a radial source. The red current is at the gyral surface or the gyral crest. So that, as you can see, is a source which is directly perpendicular to the skull. So if you use the right-hand rule, you'll see that these tangential or blue sources, they're going to produce magnetic fields which are going to go outside the skull. While these radial sources, which are basically on the gyral crest, they will produce magnetic fields which will be along the skull. So they will not be able to go outside the skull. So they will not be picked up by MEG. So MEG is sensitive particularly to these sulci. Okay. But also even to some large cortical planes like the inferior temporal and the frontal plane. But it is not very sensitive to these gyral surfaces. But EEG is sensitive to these gyral surfaces. Okay, EEG does not work very well for depth, but MEG works very well for depth, but it does not work very well for these gyral surfaces. So MEG's localization accuracy is supposed to be about 2 to 3 millimeters, but it is important to remember that it can just tell you that the activity is coming from this region. It can never estimate the source size. It can never tell you that the lesion is this big. It is this big. It is a whole brain. It cannot tell you that. It can just tell you that this dipole is here, but it can never estimate what is the rough source size. Right. So coming to clinical magnetoencephalography and what are the indications for MEG in drug-resistant epilepsy? There are 10 basic indications. No need to mug up any of these, just they're quite obvious. You don't have a hypothesis. You just don't know where activity is coming from. You can use a MEG. You have a negative MRI and you're suspecting is a mesial temporal onset. You can use a MEG to confirm. There are multiple lesions on MRI. You just don't know which one is the one producing epilepsy. So compared to a scalp EEG, a MEG would be more accurate. You have a very large lesion MRI. So a MEG can help you localize within this large lesion, where is your epileptic activity coming from? A very important indication is for reoperation cases. An EEG will get distorted by skull defects. Previous surgeries, scars, skull defects, it does not work very well with this, but MEG will not be distorted at all by these scars. Okay. Then other obvious indications, like you have ambiguous EEG findings, which are suggestive of bilateral or generalized patterns. You have areas which are not very well picked up by EEG, like an intrasylvian onset, an interhemispheric onset, an insular onset. These are all deeper sulci that MEG would better pick up than EEG would. Or you have a negative or spikeless EEG. So just very obvious indications as to why you would rather do a MEG than an EEG. Now, what possible benefits does MEG give you with pre-surgical evaluation? It is able to, as we have discussed already, it is able to localize your epileptic cortex. But apart from that, it can even localize eloquent cortices. And we'll discuss this a little bit more in detail later. But it can localize the eloquent cortices non-invasively. Okay. Just like fMRI can. So MEG can also do that. Okay. It also can, apart from that, it establish spatial relationship of the lesion with eloquent cortices. Okay. So a very common indication we discussed for subdural grid was for patients who have lesions within the eloquent cortex. So maybe in those cases, we can rather use a MEG. It can localize both the eloquent cortex and your lesion. Okay, and can tell you what is the relationship of the lesion with the eloquent cortex. Okay, it can detect functional tissue within a tumor, and it can even pick out what are the different displaced anatomic landmarks, particularly the central sulcus and Sylvian fissure. So a MEG is a little bit of a difficult technique, though, even though with all its advantages. You have to, before a patient goes in for MEG, all magnetic artifacts must be removed, and you might have to do a demagnetization procedure known as degaussing. A patient must keep very still till the end of the scan. They cannot move around. So usually patients are sleep deprived before a scan. If the patient is restless, which a lot of these patients are, now with advanced MEG systems, there are head position tracking tools which will help you with this. But there are some drawbacks of MEG results. There are some areas of suboptimal sensitivity with the MEG. Particularly with deep sources, just cingulate gyrus, a MEG is not very sensitive. Rather than identifying a primary source, it might actually pick up propagated activity, as a lot of these non-invasive techniques do. And sometimes you can get some abnormal results with MEG. You might get a bilateral MEG or you might get a contralateral MEG. Now, what is the role of MEG in epilepsy surgery? There are currently 4 general roles for MEG in surgical decision making. Basically, this is for a patient. First is a patient has been evaluated for surgery, has been deemed to be a poor candidate. Okay, but sometimes they might want to still proceed with surgery. So a MEG can help you further propel this patient along. Okay, if they're able to localize an epileptogenic zone with a MEG, it might help you to further propel the patient along the pre-surgical evaluation. Second, in a patient where you're just not sure as to whether they require intracranial monitoring or not, it can help you guide the selection of appropriate patients for monitoring. That this patient should undergo intracranial monitoring. Okay, but sometimes it might even give you enough data that you do not require intracranial monitoring at all. Okay, particularly it can tell you the eloquent cortex. It can tell you the relationship with the eloquent cortex. It can tell you where is the epileptogenic focus also. So sometimes you might not require intracranial monitoring. And also, sometimes if it picks out particular areas of dipoles, it can even improve the accuracy of monitoring because you can place the electrodes there. Right. So currently, again, as we've already discussed multiple times, second phase techniques are for patients who are obviously not safe candidates for surgery. So if they're obviously safe candidate of surgery, you would not go ahead with this. Okay. So you for patients who have negative MRIs, discordant data, multiple pathologies, and lesions adjacent to eloquent cortices. Basic indications for any further evaluation. Right. Apart from being used for uh, figuring out epileptogenic activity, we can also use MEG for functional mapping. So beyond what fMRI can do, MEG can map out even auditory and visual and somatosensory cortex. So it can map out language and motor as fMRI can, but all these other cortices also. So what you do is you basically give a time-logged stimulus and at the same time check the MEG activity in a time-logged manner, and is able to pick out these particular areas of electrical activity that might be able to help you localize these cortices. For example, you stimulate the foot and you see where the dipole is arising. So that is your foot cortex. Okay, so you can map out all these different cortices. So the most commonly performed modality is actually somatosensory evoked field. So the results are actually in the form of evoked fields. Okay, so you have somatosensory evoked fields, which can either be by directly touching that area or by electrically stimulating the nerve. You can also do motor mapping with either active movements, passive movements, or even ask the patient to imagine movements. Okay, so just even imagined movements can produce a motor evoked field. Okay, so for example, if the patient is paralyzed, okay, they can just ask them to imagine that movement. Okay. The for language mapping, it has an 80 to 95% correlation with Barrett testing for lateralizing. For visual cortex mapping, for auditory cortex mapping, these both require a lot of cooperation. And the patient cannot be sleep deprived, has to lie still, has to cooperate. That is why these two are rarely performed with MEG. Right. So that brings us to our last section for today. That is electrophysiological evaluation. So we're not going to be discussing EEG because that is the role of the neurologist. We're going to discuss what we as neurosurgeons would do. So first is subdural grid implantation. As we have already discussed, invasive monitoring is the last stage of pre-surgical evaluation. It would be indicated only if so far whatever testing you have done has shown that the patient is not a safe candidate for surgery, but you still have a hypothesis you want to test. You do not have a testable hypothesis, you do not go ahead with subdural grid implantation. You have a patient with a negative MRI, you just don't have any idea where seizure is coming from. That patient will not undergo invasive monitoring. Okay, so in this, with subdural grid implantation, the main objective, as we have discussed multiple times, is to localize what is the epileptogenic zone with respect to functional cortex. But the majority of cortex is actually buried within sulci. It is actually going to be far away from these electrodes that you put on top. So a lot of times with subdural grids, usually depth electrodes are implanted. You should not be confused. Just implanting depth electrodes is not stereo EEG. It is not the same thing. There's a difference between depth electrodes and stereo EEG, as we will discuss. But just depth electrodes are not stereo EEG. Okay, so sometimes when you want to test other cortex also, which is deep inside, you can just put a depth electrode inside. The best candidate for a subdural grid electrode is a patient who has a cortical surface lesion, because you can just put the grid on that. And the main indication for that patient is to map an eloquent cortex near a lesion which is on the cortex. So these electrodes can either be PEG electrodes, you can put them into the cortex, or they can be put on the surface of the cortex as a strip or as a grid. So these electrodes, particularly strip electrodes, can be placed even via a burr hole, but the grid electrodes would at least require a craniotomy. Now, stereo EEG, as I've already mentioned, is not simply putting depth electrodes into the brain. Okay, that is not what stereo EEG is. Basically, it's a slightly complicated concept, but stereo EEG requires the fact that you already have a hypothesis. You have an anatomy, electrical, clinical hypothesis ready, and stereo EEG functions to basically confirm that hypothesis. Okay, so you have to have this hypothesis. You have to know where you think the activity is arising from and where it is propagating. And on the basis of that, you will put your depth electrodes with stereotaxy. So that is a stereo EEG. It's not simply putting in depth electrodes. You have to have a hypothesis. You have to know where your focus is coming from, where it is propagating. And with stereotaxy, you have to put it in those particular locations. Okay, so the primary aim of these is to define the 3D spatial and temporal organization of the epileptogenic zone. Okay, so the depth electrodes that you place will sample the lesion which is identified by MRI, they will also sample the hypothesized EZ. Now, sometimes this epileptogenic zone might be the same as a lesion, or sometimes you might think it is lying somewhere else, or there might be multiple EZs. So that is where the stereo EEG comes in. And it also can sample the propagation of epileptic activity. So when would you prefer to do a stereo EEG? It is particularly for lesions that are deep-seated, where you cannot do a subdural grid, or difficult to cover with subdural grid. Or you have done a subdural grid study and that has failed. You want to expose much larger areas than you would be able to do with a subdural grid. So you want extensive sampling or bihemispheric sampling. You're thinking that the focal epilepsy is arising from an interhemispheric region. So obviously you cannot put a subdural grid in the interhemispheric region. Okay, you're thinking of multi-lobar involvement, or sometimes you also want to treat the cause with the same electrodes. So, okay, so you might want to use the same electrode for RF thermocoagulation. So then also you can consider doing a stereo EEG. The main problem is it cannot map out functional cortex. It is one thin, small electrode. It cannot map out cortex. That subdural grid can. So that, as we have discussed multiple times, is the only remaining indication to do a subdural grid. Now, how are these electrodes placed? Usually about 16 electrodes can be planned during one time, because any more electrodes in this, it usually leads to some brain edema and brain shift. Okay, that will render your stereotaxy useless. They inserted under stereotaxy, which can be under robot guidance, frameless navigation, or a frame-based approach. So you do your pre-op evaluation, you've got all your imaging, all your different studies written all ready, and then you map out the different areas that you want to put the electrodes, and using stereotaxy, just place them. Okay, the third and the last topic would be intraoperative electrocardiography, which is not the same as we have discussed so far. The basic idea is just still using the same strip or grid electrodes, but here this is done during the resective surgery. Okay, that is when it is called electrocardiography. The basic idea when it was first established was that you both stimulate the tissue, okay, and also you use the EEG recording as well. So that time, what they used to do was they used to stimulate the cortex, ask the patient what is the seizure type you're having. They wanted to confirm the aura. Okay, so that is why cortical stimulation was used that time. And later, as they saw that even without cortical stimulation, they're able to pick up spikes with just the EEG recording. These were the interictal spikes being picked up, and it was found that using these interictal spikes, it is actually good enough to pick out the epileptogenic zone. So now currently intraoperative ECOG or electrocardiography is used for two main reasons. One is after you have completely resected, you can use it to confirm that resection is complete. The second is you can use them after cortical stimulation on a functional cortex and see if there are any after discharges. If there are after discharges, indicates that within this functional cortex there might be an epileptogenic zone. Right, so that is all for today's discussion. We'll discuss a few practice questions to see our understanding of the topic. So the first one is, can you identify this anomaly? Is it a band heterotopia, a polymicrogyria, a Taylor dysplasia type 2A, or a subependymal nodular heterotopia? You can leave your answers in the chat box. Yeah, so this is a subependymal nodular heterotopia. As you can see over here, next to the ependyma, there's all this gray matter which is present. This is not a band heterotopia, because to have a band heterotopia, there should be a clear band between white matter on both sides. Okay. So which of the following is an indication of subdural grid implantation? Lesion within Broca's area, a negative MRI study, an interhemispheric focus of epilepsy, and an MRI positive clinically correlated mesial temporal sclerosis. Okay, so as I've mentioned multiple times, the only current indication for a subdural grid implantation is a lesion within an eloquent cortex. So a lesion within a Broca's area would be the only indication out of these for subdural grid implantation. Okay, so the next 5 or 6 questions are based on this particular patient and this clinical scenario. So just asking you to pay a little bit of attention here. A 25-year-old female presented with drug-resistant epilepsy with a serious semiology of head turn to the right, gaze deviation to the right, speech arrest, and non-responsiveness for 2 minutes. She had no aura and recovered after 2 minutes, but had slurred speech lasting for 20 minutes after the episode. So what type of seizure is this? Is it a complex partial seizure, a primary GTCS, a focal onset impaired awareness seizure, and a secondary GTCS? Okay, so nowhere does it say the patient became unconscious and had tonic-clonic activity. So it is not a GTCS. It is a focal onset impaired awareness seizure, which previously was called a complex partial seizure. So the answer is focal onset impaired awareness seizure. The second question related to this is, what is the next best step in the evaluation of this patient? There's no need for further evaluation and no need for antiepileptics. There's no need for further evaluation and the patient needs antiepileptics. The patient should undergo an MRI or the patient should undergo an EEG. Okay, so obviously the first and the second are wrong answers over here. The only confusion you can have is between an MRI and EEG. For a patient with a very obvious focal epilepsy, the first diagnostic technique would be an MRI. Right. So our MRI is depicted towards the right, as we can see here. What is the next best step for this patient? Is it resection, to do a functional MRI, to do a MEG, to do a subdural grid implantation, or to do a video EEG and a neuropsychological assessment? You can take your time. Okay, so let's remember what the patient presented with. They have not presented with a glioma. They have presented with a drug-resistant epilepsy. And for the evaluation of drug-resistant epilepsy, the first phase always includes video EEG and neuropsychological assessment. So the next step is to do a video EEG and a neuropsychological assessment. Right, so she underwent a video EEG and a 48-hour video EEG showed 8 episodes of seizures with semiology seizures were focused on the left inferior frontal gyrus. And 3 episodes of seizures such were focused in the right mesotemporal region. Which of the following is the next best step? Is it surgery for the left hemispheric lesion? Is it surgery for the right hemispheric lesion? Surgery for both lesions? Further evaluation with PET MRI or further evaluation with stereo EEG? Okay, so again, let's remember the patient is being evaluated for drug-resistant epilepsy, not for glioma. Okay, just because you see a glioma does not mean you go ahead and resect it. The patient has come with drug-resistant epilepsy. You cannot operate this left hemispheric lesion because it is in an eloquent cortex. You cannot operate the right hemispheric lesion because you have no proof that removing this lesion will create cessation of epilepsy. You cannot go ahead and operate both lesions. You again have no proof that removing both lesions will create cessation of epilepsy. So this patient is currently not a safe candidate for surgery. right? So when a patient is not a safe candidate for surgery after your first phase investigation, you go on to your second phase investigations. Before invasive monitoring, always non-invasive monitoring. So the answer is PET MRI. So the PET MRI showed the following findings. Now, after this PET MRI, which amongst the following would you consider for this patient? A right anterior temporal lobectomy and AH, resection of the left insular glioma with awake monitoring, awake craniotomy and language mapping, both of the above, further evaluation with MEG, or further evaluation with stereo EEG. Okay, so this PET MR is clearly showing there is hypermetabolism in the left side, right? So there's no point of considering a right atrial NAH over here. Sorry, I'm sorry. Yeah, this is right side. Yeah. So the first thing is that this patient, even though they have a hypermetabolism on the right anterior temporal lobe and in the mesial temporal lobe, does not mean that the seizures are arising only from this area. Okay. Clearly, video EEG so far has shown that seizures are arising. The majority of them are arising from the left inferior frontal gyrus. Okay. Now, some seizures supposedly are arising from here, but there's still no way to prove that this is not secondary seizure activity, which is propagated from the other side. Okay, this might just be secondary MTS. So here, you cannot be sure that resecting this lesion will provide any benefit to the patient. You also cannot be sure that resecting the left insular glioma will also provide benefit to the patient's epilepsy. So again, patient continues to not be a safe surgical candidate for this particular scenario. Now, does that mean should you directly go in for invasive monitoring, or should you still consider doing further non-invasive monitoring? The idea is still you would further first complete all your non-invasive monitoring before you would subject the patient to invasive monitoring. So the correct answer in this case would be to further evaluate the patient with MEG. Right. So MEG in this patient showed clustering of all dipoles in the left inferior frontal gyrus. Which amongst the following would you offer the patient next? No surgery due to poor chance of seizure control. Surgery for the left insular lesion with guarded prognosis for complete seizure control. Further evaluation with subdural grid mapping of the locomotor cortex around the left insular lesion. Surgery for both left insular lesion and right mesial temporal sclerosis. Or further evaluation with stereo EEG to confirm the localization of the epileptogenic zone. Okay, so if you remember, one of the advantages that we discussed of MEG was that sometimes it can obviate the need for invasive monitoring. MEG has clearly showed that all the clusters are in the left inferior frontal gyrus. If there were a few clusters in the right mesial temporal region, you would further consider using stereo EEG. Or you might just be like, okay, there's a poor chance for seizure control, might not go ahead with surgery. Or you might consider surgery for both lesions. But when MEG has clearly shown that all the dipoles in the left inferior frontal gyrus, the patient is now considered a candidate for surgery for the left inferior frontal gyrus. But since it is the left inferior frontal gyrus, patient is still not a safe candidate for surgery. So you have to identify the relationship of this lesion with the speech areas. So you still require to go ahead with subdural grid mapping of the local cortex. So you can figure out what is the relationship of this lesion to the speech areas. Okay, so in this case, the answer would be number 3. Now, somebody asked in the previous example if MEG was not there, which it is not there in a lot of centers. Could you go ahead with stereo EEG? Yes, you can definitely go with stereo EEG in cases where you do not have techniques like MEG. Right, so that is all for today's class. Thank you so much for attending. If there are any further doubts, you can leave them in the chat box or in the feedback form afterwards.